So, inhibitors in oral care. Um, is there a protocol in place? This is my disclosures. And I thought hard about this. And is there a protocol in the UK? No. Very simple. We don't have a protocol. I don't think we will ever get a protocol. What we can do is give advice as to how to try and manage a very difficult situation. Inhibitors occur, and whilst ever patients are getting factor VIII and factor IX, we will have patients with inhibitors. So, management of patients with inhibitors, what's the ideal situation? Well, we need a proper dental team. I don't believe that these are patients who should be passed out from a major centre to general practitioners. These are complex patients. They need to be held and treated in the centres. The numbers in most haemophilia treatment centres are small, so therefore it's not going to overload the system. And the dental team needs your dental surgeon, a dental nurse, a hygienist or therapist with access to oral surgery, orthodontics, specialist restorative treatment, specialists in endodontics. So all the subspecialties that we normally would expect and we would refer any other patient to, we need to have available to us. But most importantly, and this is something I've been talking about a lot, we've got to be an integral part of the comprehensive care team, the multidisciplinary team, whatever you want to call it, related to the care of the patient. There are many diagrams which show this, and this is one of the simpler ones. Some of them have got many more red circles around the outside with different groups of people. But the crux of it is the patient is in the middle, and as far as we're concerned with patients with inhibitors, it's really the dental team, the laboratory technicians, the haematologists and the nurses that are going to be important. They're the important players. Now, one of the interesting things which I learned at the Global Forum in Montreal is that actually the Bethesda assay is difficult to run. And I believe that in America they now have moved it all to one centre for doing the definitive testing because of this. So we've got the patient with inhibitor. What do we do? Well, we've got potential problems with bleeding. Worse with patients with inhibitors than with patients with factor VIII and factor IX because it's not as easy to treat. The question that the doctors have got is what product do you use and what are the dosing guidelines? And there don't seem to be any good dosing guidelines either. Access to treatment for the patient. That may seem simple, but Alison's been talking about cleaning, toothbrushing with elbow and shoulder problems. A number of these patients have got hip, knee, ankle problems. So actually access to a surgery may not be as easy, even if it is on one floor because of the distances involved. If their car is parked 200-300 yards away from the surgery, getting from the car to the surgery may not be as easy as it sounds. There's always with these patients the thought of risk of infection with hepatitis B, hepatitis C, HIV, variant CJD. I know there's probably more, and I'm just listing the common ones. Prevention. I don't think there's any debate in the dental field that this is the treatment of choice. It's the key issue. We have to prevent problems. How do we do this? Well, In the earlier session and on Sunday in the workshop, we were talking about babies having their first dental examination before they were 1 year old. Before they were 1 year old. We were talking about a dental home. And I think for patients that develop inhibitors, the dental home is very important. But it's very important that we maintain good records, because it's our knowledge of what we've done for that patient that's going to help us in the future. The patient should get regular dental examinations. Now that's fine, as we've said, with the children and with the older population. We've got the transitional group who tend to be a bit wayward, and I don't know if there's a good way around managing those patients. The dentist should arrange regular visits to hygienist. Fluoride supplementation. Orthodontic evaluation and treatment as required. Dietary advice. Now, I know that we could argue at length over what order these are in, and I'm not trying to make it, this is the order it should be done in. These are the items we should consider. Treatment planning. Simple. What is required? What do we need to do for this patient? Where are the difficulties? Access. Have we got partially erupted teeth? Have we got overcrowding? In the 18-year-old-ish group, you've got potentially impacted wisdom teeth coming through. I think it's very important with all patients, but particularly this group, to discuss and agree your treatment plan with the patient, or for the children, with the parents, so that they actually know what you're planning, how you're planning to do it. And then the next question I always say, look at is cover required? Now we looked at depth yesterday at local anaesthesia, which is the workhorse of our anaesthetic protocol. We know that for restorative treatment, we do not need cover for the majority of treatments. We sometimes do for periodontal disease if it's got out of control, but for restorative treatment, we don't. Using modern local anaesthetic techniques and ideas, we shouldn't need to use local anaesthesia, cover for any local anaesthesia. You've then got to ask, do I need to refer? We've got specialists, there's two of us who are specialist oral surgeons in the room. We've got a number of pediatric dentists in the room. We've got somebody who's a specialist in geriatrics. Do we need to refer to them for specific advice, specific treatment? Or do you want to use an endodontic colleague or something like that to maintain teeth? And a summary of local anaesthesia. I'm not going to go into this in depth, but by using the techniques on the right, where I've put no problem, which means we don't need to use cover, we can anaesthetize every single tooth in the mouth adequately for restorative treatment. The ones on your left, the ones on your right are the ones that we would need to use prophylaxis for, and they tend to be related to patients where we are extracting teeth where we need prophylaxis anyway. So the bottom line is that for restorative treatment, we don't need it. If we need to do any extractions and surgery, this is where the problems occur. And I'll summarize it very quickly and then go through it in detail. We need appropriate cover from the haemophilia unit. And I'm using the word appropriate because they will determine the product, the dose, the frequency. All the textbooks say atraumatic treatment. Now, how we can do an extraction without causing any trauma, I don't know, but I'm using that because that's what the textbooks say. Consider antibiotics. I would only use antibiotics if I would use it in any other case. I wouldn't use it just because they've got inhibitors. And then as a minimum requirement, we would observe them for 2 to 3 hours afterwards. and give them comprehensive post-operative instructions. Now, for an extraction, and we'll look at this in more detail, which is probably the commonest thing, we would construct a protective splint if possible. The reason I say that is you need a tooth distal to the tooth you're extracting. If you're taking the last tooth out, the splint doesn't work very well because you can't put any pressure on. And just to show you, we've got, this is just an arch. The darkened tooth is the one that we are planning to extract. So we take an impression, and the technician casts a model and carves that tooth away. We then use a vacuum form device. This is an older one. Some of the newer ones are all enclosed. It doesn't matter which one you use. They all do the same thing. You want a 3mm soft splint. You suck the splint down, and it looks something like this. We always cut a horseshoe out of it, although it comes with palatal coverage, because we don't need the palatal coverage. And we use that over the socket at the time of surgery. In Glasgow, and I'm using mainly the protocol we use in Glasgow, because as I say, there's no consensus, but at least this seems to work. We use a tranexamic acid mouthwash an hour before the procedure, at the same time as they're getting the appropriate treatment from the haemophilia centre, which tends to be factor VIII inhibiting bypass agent or factor 7A. So they're the two treatments we would tend to give. The very mild, if you've got a patient with less than 5 Bethesda units of inhibitors, we have used double or triple dose of factor. But at the moment, none of our patients are at that level. Administer the local anaesthetic, and the important thing here is give it time to work. Extraction of the tooth. I've changed it to here as carefully as possibly, because I think that's a more apt description. Insert a hemostatic agent into the socket. And again, this could be oxidized cellulose, fibrin glue, or flow seal. Depends on what you've got available, what you're used to. I tend to use flow seal because we've got it available, and I think it's about as effective as fibrin glue, but it's not. It's made for. It's a recombinant product. It's not a human-derived product. Suture the socket if appropriate. If you're using fibrin glue or flow seal, we often don't suture the socket because this actually still sticks the socket together. Fit the splint. Continue with tranexamic acid. 1 gram 3 times a day for 5 days. We ask the patient to take the splint out the next day, clean it, and reinsert it, and leave it like that. Additional doses of factor are given as required by the haemophilia centre. However, things are changing. And there are some new and novel therapies coming on the market, which I'm going to introduce. We've got monoclonal antibodies, which is emicizumab and fitusiran. There are probably others on the market as well. And we've had gene transfer. Gene transfer is probably the one that's been on the news more for both factor 8 and factor 9. At the moment, they are both of these two treatment modalities are being used for patients with inhibitors. The idea is, with the monoclonal antibody, it's a weekly injection. It promotes different parts of the pathway so that your inhibitors stay, but the patient clots. Now, the problem is, we don't know what the levels are. There is guidance for surgical treatment of patients. However, as Branislav said in the last talk, we shouldn't be following surgical guidance. We need to develop our own guidance, and this is something we will need to do, but we don't know. We do need to be very aware that we cannot use some of the normal treatments you use with patients with inhibitors. In fact, there have been a number of fatalities because patients have gone back to their old treatment whilst on the monoclonal antibodies, and they've had a fatal thrombosis. So we have to be very careful. And this is somewhere that we will need to talk to the companies as to how we manage them. Getting some basic protocols. I'm not saying fixed. Gene transfer, this is somewhat simpler, I think. If the gene transfer works, the patient starts to produce normal levels of factor VIII or factor IX. More commonly, it seems to bring them up from being a severe to a mild. Some of them don't actually make it into the normal, but they make it into the 40-odd%. How long does it last? We don't know. 5 years is probably as long as we can say because we haven't got the data. There's one patient in the UK where they're actually worried that his levels are continuing to rise. So is this going to become a problem? If it gets too high, what happens? So again, an area where we will need to be aware and to develop something to say. So, in summary, patients with inhibitors pose a significant challenge when we're talking about dental care. Prevention is the mantra for treatment. Any extractions and surgery must be performed with the full support of a multidisciplinary team. Close liaison with the Haemophilia Centre is important. And careful follow-up is required. We need to be aware that these patients do bleed, do have problems. We need to provide 24-hour cover for them. The new and novel therapies, as I said, pose an unmet challenge. I don't know of any extractions that have been carried out on these patients, so we don't know what's going to happen. Thank you.